and I wish to congratulate all of us for the work that we are doing. SOMTABA, as you know, we're a women's rights advocacy organization, and we work closely with categories of women, at the urban, peri-urban, and rural communities. And so we understand that issues about health is not just about the availability of hospitals or healthcare centers. It is also about the intersectionalities and issues that affect their ability to access those facilities. And for us as an organization, this couldn't have come at a later date, since we are going to use data to support the advocacy that we do. And as an organization, we understand that health-seeking behavior of women is influenced by a complex interplay of many factors. Come to think of it, we have issues around cultural belief, we have issues around the disease pattern, as we may see, and then also health literacy, which all contribute to accessing healthcare services. And so as we look forward to this discussion, SOMTABA, together with 8 partners, would use the data to do and strengthen our advocacy efforts, in assessing health. Because we're not just looking at women, we're also looking at women in their diversity, women in rural areas, women who are, excluded, women who are even persons with disability, and then women who are FUBE, for example, who are much excluded and have less voice. How are their ability to access health, and what challenges do they face? And I want to believe that this data will expose a lot more for us to enhance our advocacy. So I look forward to a very good discussion. Thank you very much.
Thank you very much. Thank you, Hajia. You've raised very critical issues. The complex interplay of many factors, including location, health literacy, and also even women's diverse circumstances, the FUBE, disabled women, and various others with different challenges. Thank you for those drafting comments. Auntie Mavis, you have been drafting policy recently. We welcome your opening thoughts on the subject. Mavis Adujabuke.
Thank you, Auntie Ofe. Please, good morning again to everyone. It's an honor to be here. I bring you greetings from the ministry, the minister, the chief director, and the director PPME. She would have loved to be part of this meeting, but she has to be in an equally important meeting. So on this International Day with the team, From Data to Action, Strengthening Women's Health and Access to Service, the team underscored the critical role of evidence-based decision-making in addressing gender disparity in healthcare and ensuring equitable access and essential services for all. We all know that gender influences health outcomes, and women and girls continue to face some challenges in line with maternal health, limited access to reproductive health care, gender-based violence, and social and economic barriers to healthcare services. Whilst we have made notable progress in improving women's health, there is still work to be done. It's in line with this that to advance or in line to address some of these things, the Ministry of Health, with support from UNICEF, as mentioned earlier, has revised the health sector gender policy. The policy aims to ensure that gender considerations are systematically integrated in all health planning, service delivery, and monitoring. So the priority for the ministry currently is to disseminate the policy widely across the health sector. So I will take this opportunity to ask everyone to help us in disseminating this policy wherever you are. So in our call for in our commitment to enhancing women's health, the ministry is still committed to strengthening maternal and reproductive health services. We are so committed in enhancing gender-based violence and health implications, in addressing gender health. We are so committed in addressing gender-based violence and health implications. We are committed in expanding data-driven, gender-sensitive health policies, and also enhance access to essential health services. Lastly, we are committed in promoting universal health coverage with gender lens. As we observe this day, we call upon all to affirm our responsibility to translate data into action by strengthening gender-responsive healthcare policies and also ensuring equitable access to services for all. Thank you, and over.
Wonderful, wonderful, wonderful. We started on a very exciting note. I think that we are deeply assured by your observations, the fact that data gives us the backbone of evidence-based decision making. We are delighted that there is this policy to ensure systematic integration of gender and health planning implementation, monitoring and evaluation. We pledge our support in helping to disseminate this policy. You know, we are on site already. And the areas of focus are also equally interesting. The commitment to maternal and child health, gender-based violence and its health implications, generating relevant data for gender-sensitive planning and implementation, and enhancing access to essential health services and resources, and above all, universal health coverage with a gender lens. So I think we are even identifying the pathways already, and it puts us in a good space to move forward. But what are the issues on the ground? What are the concerns that we're looking at? That is why we undertook this study. I mean, it's good for us to state these intentions, but we need to know what is on the ground in order to be able to intervene effectively. So on that note, I want to invite Mr. Benjamin Okon-Tracy, Program Manager, Policy Analysis and Advocacy at the Alliance, to share with us in 20 minutes the findings of the study. I think it's a very exciting study, but we need to be able to glean something to work with. Over to you, Benjamin. Thank you.
Good morning, Auntie Esther. Thanks so much for the opportunity to lead the discussion, and thanks to colleagues from Alliance for Reproductive Health for nominating me to lead the presentation today. And good morning, fellow panelists. Thanks for being with us to share input in our baseline dissemination. So this presentation is based on the baseline conducted last year, late last year, from December to January. And we were able to explore the challenges that gender inequalities pose to primary health care access in Ghana, particularly how power dynamics shape women's ability to make healthcare decisions in Ghana. Women's empowerment continues to be a global challenge, and Ghana is no exception, as it has been espoused earlier. Studies by ASEDO indicate that 50% of women and girls aged 15 and above face barriers to quality primary health care. These barriers exist on two levels, both the supply side. When you say the supply side, we are talking about health facility providing the services, and then the demand side, looking at those going to seek services. Barriers at the supply side it's an issue because in most of our communities, the first point of healthcare is the CHIP zone or is a CHIP zone or the health center. And many of these health facilities are far from rural populations. That's what studies indicate. And making access difficult, especially for women who depend on family approval or financial support. So most women from the review we did have to get approval from their husband before they are able to seek medical care. NHIS coverage, though widely available, but does not fully cover all necessary healthcare services, leading to out-of-pocket payments. And most people visit the facility and they don't even get the medications they are there for. On the demand side, women face significant challenges in accessing healthcare services. Social norms often require women to seek permission from their spouses before making health-related decisions. Many women lack financial independence. They don't even have funds when you go to our communities. They don't have funds to pay for their medical care when they visit the facility. Moreover, the healthcare feedback system too is a challenge. So it's more of a supply-driven, meaning that the perspective of clients, who mostly women, are not able to adequately give their feedback so that it to be incorporated into the healthcare service delivery. Looking at women's agency and leadership, the review we did before the research indicated that women's leadership is critical in shaping healthcare policies and improving service delivery. However, there is a limited representation of women in key decision-making bodies, which as health management, example is a health management committee. So you visit our communities, they have health management committees, which we think women should participate so that they will be able to voice their problems. They will be able to tell what they need so that their unique things that they will require from the health facilities are taken care of, but you don't see that when you visit the communities. And this informed our baseline study. We conducted a study in the 7 regions as shown in the map on this screen. Our objectives were very simple. We wanted to assess the gender and power dynamics affecting primary healthcare decision-making. Also to identify the barriers that prevent women from participating in healthcare decisions and to explore strategies for strengthening gender-responsive policies. Our methodology was purely quantitative due to the time limit. We couldn't go into qualitative to get more in-depth from the women, but there were a lot of open-ended questions that gave us a lot of good data for us to share. So we're able to engage 558 respondents, evenly split. So we have 279 females and 279 males. The average age we found was 33 years. The data was collected through structured surveys and focused discussions. So now let's zoom into the findings. If we critically look at the level of education, at the primary level, women, we will find a lot of women, about 22% of them at the primary level. But then as they move along the rope, most of them dropped. So you will see that we have a lot of women attaining primary level education. But when you get to the secondary level, the number dropped. And at the tertiary level, you may find few of them. And education plays a very crucial role in empowering individuals to make informed health decisions, which you agreed with me. So there's a need for us to so intensify our education, empower the women so that they will be able to understand and be able to decide on their own when it comes to health matters. There are disparities when it comes to regional breakdown, and most of the regions may have primary level education as the highest education, but there are other regions that have no formal education at all. And as social workers, when you go to the communities, they should inform how we educate or how we communicate to the community members because their understanding may be different. So when you're communicating to them, you have to put in perspective